Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be on the CT of parenchymal liver disease. There's no doubt when you start looking at CT and where protocols become very important and where you see pathology on what seems to be almost every patient, the liver becomes at the top of our list. Now, I will give in this series a couple talks. One will be on liver masses. This one I'm going to focus on parenchymal liver disease, talk about some of the basic principles, talk about some of the various pathologies, but also start about talking about protocols. So in terms of protocols, when we're doing dedicated liver studies, we'll always distend the stomach with water, give about 1,000 cc's. Now you could say, why do you bother? Well, if you don't distend the stomach, then potentially you can have pseudotumors where people are uncertain if there is gastric pathology or not. So distending the stomach works well. Also, since we're giving IV contrast, by using water, we're hydrating the patient. And our experience has been with agents like Visopaque or Omnipaque, which are indeed very safe contrast agents. Hydrating the patient is another additional step. So you never could overhydrate a patient. So that indeed becomes very important. Now I mentioned we use water as a routine contrast agent. You can use oral iohexol, oral Omnipaque in a low density solution, but we typically do that for some of the other pathologies. I tend to like water when I'm doing the liver. So what can we do? If you think about the liver for a moment, kind of like when I spoke about the kidneys, there's a number of things you can do. You can do non-contrast scans, you could do arterial phase, and arterial people speak about early and late arterial phase. You could do venous phase imaging and late phase imaging. Obviously, you want to have enough phases to answer the specific questions, but not to over-radiate the patient. And we'll discuss what phases we do get. Now, when we do arterial phase imaging, there was some articles written about early and late arterial phase. One article showed things to be a lot better in early arterial phase, but it was only one article. Reality is most people think about arterial phase as about 25 to 30 seconds after the start of injection of contrast material. We routinely inject at 5 cc's a second. For a patient with good cardiac output, a 30-second delay works well. If you have a patient where you're concerned about timing, then it's easy enough to do a triggering point. What I typically will do is the level near the diaphragm, use the abdominal aorta, depending on your scanner and depending on your injection rate, trigger anywhere between 200 and 250 Hounsfield units. For the faster scanners, something like a dual source, you might trigger at 250 Hounsfield units if you're injecting 5 cc's a second. Now, in terms of the protocols, we always use the thinner detectors, and we do reconstructions with thin sections, 0.75 millimeters, as well as with thick sections. With the thin sections, we do 0.75 at 0.5 millimeter intervals, and then what we're able to do is create very nice three-dimensional and MPR maps, as I'll show you. The studies are very quick, and you can see the importance of timing in getting the right answers. If I speak about parenchymal liver disease, I can give you a list that would fill up many slides, but here are some of the common pathologies that we do discuss, ranging from fatty infiltration of the liver, which is particularly common these days, to cirrhosis, to abscesses, to infarct. So let's go through some of these and look at some of the key points. Now, fatty infiltration of the liver was always something we spoke about on CT. It's also known as hepatic steatosis. It's becoming more important because a number of articles, as I'll discuss, show the relationship between fatty infiltration of the liver and coronary artery disease. And seeing fatty infiltration in a younger patient would suggest they're at a higher risk for developing coronary artery disease. When you speak about fatty infiltration, there's a number of different causes. It could range anywhere from dietary to trauma to ischemia. It can be focal or it can be diffuse. When it's diffuse, it's very easy to recognize. In most cases, even when it's focal, it's easy to recognize. But occasionally, focal fatty infiltration can simulate hepatic tumor or some other mass-like process. When you look at some of the numbers, 7 to 10% of patients undergoing liver biopsy have non-alcoholic steatohepatitis. Obesity is the biggest risk factor for non-alcoholic fatty liver disease. Up to 30% of obese patients have non-alcoholic steatohepatitis. and non-alcoholic steatohepatitis, or NASH as is better known, will probably become the most common chronic liver disease within 20 years based on the epidemic of obesity in the world. A number of different articles have been written. This article by Lau a couple years back, the inflammatory subtype of non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, is becoming one of the most important causes of chronic liver disease. We always kind of look at fatty infiltration of the liver and kind of think it's a benign process, but you can see it's really often the signature of something important going on. Clinical presentations from diabetes to hyperlipidemia to hepatitis, parental hyperalimentation, malabsorption, steroids, and trauma are just some of the things. Now, when you ask the question, how do we recognize fatty infiltration of the liver on CT? There are typical things we look at. When the classic description would be that the liver attenuation is lower than the spleen. Typically on CT, from the beginning, it was always said that the liver had a higher attenuation than the normal spleen by 7 to 10 Hounsfield units. That typically was on late venous phase imaging. And that's one way of looking at it, that if the spleen is denser than the liver, there's fatty infiltration of the liver. Obviously, you need to be careful. You want to make certain you're not looking at arterial phase imaging or imaging where the spleen is very bright. And so these days, with fast injection rates on early phase imaging, the liver is often lower attenuation than the spleen, almost always, in fact, because the spleen is so bright. So when we speak about liver being lower attenuation than the spleen, we're talking about those situations with later phase imaging, 4 or 5 minutes out, or a non-contrast CT. The other thing to compare the liver to is something that we know as a set density. Paraspinal muscles usually are solid density, 50 to 60 Hounsfield units. One of the interesting things also is that vessels are seen through zones of fatty infiltration without distortion or invasion. We know that one of the classic ways of distinguishing focal fat versus a mass when you're uncertain is look at the vessels. If it's a tumor present, you may not see the vessels or the vessels are distorted. If there's no tumor present and it's simply fatty infiltration, you're going to see the liver vessels very nicely. What are the current definitions of fatty infiltration of the liver? Now, the first thing is that people have shown, and it's a good point, that if you're going to look for fatty infiltration of the liver, you don't need contrast CT. You want to do a non-contrast CT. That gets around all of the issues with timing. And so when you look at it, there are a number of different definitions I've read. Liver attenuation under 40 Hounsfield units, liver attenuation less than or equal to the spleen minus 10, liver attenuation equal to or less than the spleen, liver attenuation less than or equal to the spleen plus 5 Hounsfield units, liver to spleen ratio less than 1.1. And all of those have been definitions, but the one you really want to look at is liver attenuation under 40 Hounsfield units. And there's been several articles. This article by Kadoma, measurement of attenuation of the liver on non-contrast CT is best for prediction of pathologic fat content. Article by Boise, assessment of liver attenuation by unenhanced CT represents an objective and non-invasive means for detection of asymptomatic hepatic steatosis, whereas clinical risk factor assessment is unreliable. In that same article, it remains unproven whether the subset of individuals with moderate to severe fatty liver disease are truly at risk for progression to steatohepatitis or cirrhosis, and follow-up is planned to answer this question. So there's still a lot known about fatty disease in the liver, but there's a lot that really we are going to learn over time. And I think a lot of it is going to be that it's much more important perhaps than we were really thinking about in the past. If we look at hepatic steatosis, we talk about non-alcoholic fatty liver disease, which often goes by NAFLD. It's a common cause of chronic liver disease. Obesity is the primary risk factor. It occurs in up to 25% of adults, and about 25% of these patients develop NASH, which is an inflammatory subtype of NAFLD. It can progress to cirrhosis, and NASH and NAFLD really can't always be distinguished on the basis of imaging. Patients with non-alcoholic fatty liver disease, even without metabolic syndrome, are at high risk for atherosclerosis. Again, the comment I made before, if we see fatty infiltration of the liver, perhaps that patient needs a coronary CT or see a cardiologist and get your cholesterol checked, or probably both. Patients with non-alcoholic fatty liver disease, again becomes very, very important. This point about being a strong predictor of subclinical coronary artery disease. So again, I think when you see fatty infiltration on CT and it's not somebody who has a good explanation like recent trauma or the patient's been on hyperal, you should say that this is a risk factor and perhaps the patient should be worked up for subclinical coronary artery disease. At least get a cholesterol set of values if the patient's over 45 or 50. Then a coronary CTA may be a bit much, but calcium scoring may be the right thing to do. Now, in this spectrum of fatty infiltration, there are a number of specific things that we do see. We see often these days chemotherapy-related fatty liver, which goes by CASH. It's common. It's caused by a number of different drugs. It's important to mention only it could be an explanation why the patient may have elevated liver function. Sometimes when you see elevated liver functions, everyone's worried about metastatic disease in an oncology patient. It may simply be this chemotherapy-related fatty liver. And here's a very common presentation. The liver is a touch enlarged, chordate's a little prominent, spleen's normal in size. When you look at the densities in the non-contrast CT, the liver was 18 Hounsfield units, spleen was 48. There's definitely a difference, obviously, fatty infiltration of the liver. And even if you didn't put measurements and you eyeballed it, you can see the liver is really of low attenuation. Just compare it to the spleen or compare it to the paraspinal muscles. You see the spleen on non-contrast and the paraspinal muscles have almost the same attenuation. Another example. Now, one thing at times that can be tricky, we talk about focal fat simulating malignancies. We talk about the difficulty sometimes in picking up lesions, but the fact is lesions often will show better because of fatty infiltration. Here's a patient with colon cancer and liver metastasis. Now, sometimes those hypodense lesions look relatively vascular, at least the periphery, because it's relative to the edge of the normal liver. And you can see in a case like this, another example, multiple tiny cysts within the liver, as well as areas of fatty infiltration, as well as areas of metastasis, or in this case, focal sparing in a patient with metastatic disease. So you need to be very careful. I think at times it can be tricky. Fatty infiltration does make our job a little bit more difficult. There's at times the tendency to overcall the presence of metastasis, but I think when you look for the full sequence of images, it's usually not that difficult. Obviously, we're typically not looking for metastasis on a non-contrast CT scan. Now, when you talk about low density in the liver, there are a number of things we think about. We think about injury to the liver, acute hepatitis. Now, often with acute hepatitis, the liver may look normal on CT, or it can be edematous. You can see ascites, you can see edema around the gallbladder wall. We talk about fulminant hepatic failure. Patients with acetaminophen overdose, you get acute fatty infiltration or acute low density in the liver, and that's really, in a sense, infarction. We talk about infection. We talk about lymphoma occasionally. And we should mention that almost any tumor at times can be infiltrating, but usually it's not going to be a difficult diagnosis. Lymphoma at times can indeed be very tricky. So a couple examples, this patient with acute hepatitis, you see the vessels very nicely from the IVC to the hepatic veins, and you see the diffuse fatty infiltration of the liver. The liver is low density. So that's a very important example. Now, when we speak about cirrhosis, chronic liver disease, it's characterized by fibrosis and necrosis of the liver parenchyma, is what cirrhosis is. In the U.S., alcohol abuse is the most common cause, and it becomes the 6th leading cause of death in the USA. It involves billions of dollars in hospitalizations a year. It involves GI bleeding. It involves portal hypertension. It involves patients for liver transplants. It's really a tremendous health problem in the United States, one that, in a sense could be avoided. It's very much like smoking, but again, alcohol abuse is the problem. Cirrhosis can be due to other things, hepatitis B and C. The good news is there are new drugs which can treat this. Biliary cirrhosis, primary sclerosing cholangitis, and certain medications are all causes of cirrhosis. But number one on the list is alcoholic abuse, alcoholic hepatitis, that whole spectrum of disease. Now, when you look at cirrhosis, what are you looking for on CT? It's the classic thing we all know. It's a nodular liver, and the liver changes shape. The left lobe gets larger, the right lobe gets smaller, the caudate often gets big. There's increased distance between the abdominal wall and liver surface. The liver is becoming nodular and retracting. The nodularity to the liver will vary, with nodules often seen in non-contrast CT as higher density nodules. You may also see hypervascular nodules on the arterial phase. Now, often those are going to be hepatoma, but you may see small nodules, which, yes, could be hepatoma, but can be regenerating nodules as well, and we'll speak about that. The CT findings you can see here, again, some of the magic numbers. Caudate hypertrophy, segmental hypertrophy of segments 2 and 3, with atrophy of 6, 7, and 4, enlarged gallbladder fossa, peribiliary cysts, enlarged periportal space, are all things we can see with cirrhosis. And here's just a nice example, and you know this is cirrhosis. You see the nodularity in the surface of the left lobe of the liver, you see the big fissures, you see the big caudate lobe. The spleen is not enlarged, at least on these sections, and it looks like there's a mass in the esophagus or GE junction, which, as you can guess, when we look at venous phase, will be large varices. Just a couple more images. You can see the textural, this sort of grainy appearance to the liver. You don't see any focal lesions. You don't see any AV shunting, but you might. And you can see in that case, as you go to later phase imaging, when you go to venous phase, you see the large varices in the esophagus and gastric fundus. You see the nodularity to the liver, and you see a slightly modeled enhancement pattern, which is again shown here as well. Now, in patients with cirrhosis, we always worry about hepatoma. Most commonly, hepatomas are best seen on arterial phase imaging, less well seen on venous phase imaging, but that's not always the case. You need to look indeed very carefully. This patient has a tiny cyst in the right lobe of the liver, which is also seen on the reconstructed views. The recon views, this is volume rendering, very nicely show you the large varices in the gastric fundus and lower esophagus, and the spread of varices in the collateral pathways are particularly nicely seen in the same case on these MIP images. Remember, MIP is a projection technique. I mentioned in other talks about MIP when there's lots of collateral vessels, be it pancreatic cancer with vessel encasement, you really get a feel of the extent of the collateral pathways. Now, sometimes with cirrhosis, it's not an easy diagnosis. You know this patient has severe liver disease by the nodularity of the surface, by the caudate lobe, but what about the enhancement pattern? Could this be multifocal hepatoma? Could this be METS? Is this AV shunting? Is this regenerating nodules? Here it is on the coronal view. What exactly is going on? You can see the branching of the hepatic artery shown again here, right and left hepatic arteries. The vessels are somewhat stretched, but there's no neovascularity coming off the vessel. And when you're looking at this case, what you're really seeing is a nodular pattern, small regenerating nodules, areas of AV shunting. You can see as you go to venous phase, the large varices, and that mottled appearance to the liver, how the areas of the liver are diffusely changing in terms of appearance. Here it is again, that nodularity, and this is very classic for cirrhosis, though I will admit when you have a liver that looks this bad, it's very hard to exclude something, for example, in this case in the left lobe, and say there's no hepatoma present. It can be tricky. At times, MRI can be very helpful in this regard. Again, looking at the sequences from arterial phase through venous phase, usually you can be certain that there isn't hepatoma present, but sometimes it's very hard. People have done delayed phase imaging. I've never really found that to be all that helpful. Another example, cirrhosis, ascites, the portal vein is patent. We look at portal vein, splenic vein, SMV for patency. With cirrhosis, you often will see a wet bowel pattern. You can see very nicely the wet bowel, the small bowel. Here it is again with a few more images. With cirrhosis, the liver is congested. There's mass effect, so you may see compression of the IVC. The IVC is typically patent, but it can be compressed. And then, of course, looking at the portal vein and SMV, the vessels in this case were patent, nicely shown in MIP imaging, but you see the very large branches coming off the SMV and IMV. You really can appreciate the portal hypertension and the collateral flow pathways that are very nicely seen. In this case, however, when you look at all of the images, you don't see hepatoma, you see the irregularity. You feel very comfortable talking about this being a cirrhotic liver, nodularity, portal hypertension, ascites, but no evidence of hepatocellular carcinoma. And here's just a few more images showing you MIP and volume rendering. And I particularly like the MIP for looking for any neovascularity, as well as looking for the irregularity of the vessels, as well as for showing the patterns of collateral pathways. Now, in this case, I mentioned the wet bowel pattern. Wet bowel is common in patients with cirrhosis and portal hypertension. It involves both small bowel and large bowel. In the small bowel, the bowel just looks wet. It looks edematous. The folds are thickened. Transit time may be a little bit slow, but there's no obstruction. It's this really edematous pattern, very nicely seen, and you can see it's matched. Look at the portal hypertension. Look at those very large, what look like boggy vessels, and so it matches really perfectly when you go from the MIP to the volume rendering. And again, looking at the vessels here, yes, the portal vein and splenic vein and SMV are all patent, but you can see the portal hypertension with the very large collateral pathways. Now, in this case, I showed you the small bowel was thickened, but you also can see large bowel thickening. And one of the important things to know is it's a great pitfall. You commonly see bowel wall thickening, let's say large bowel, and you're thinking colitis. Well, if you have end-stage liver disease or just severe liver disease, if you see right colon thickening, I always say it's consistent with changes related to the patient's cirrhosis. If you see a pancolitis or it involves a transverse colon, then I'm worried, does this patient have colitis? Remember, a lot of these patients are on numerous medications. Patients could have pseudomembranous colitis. So again, it's important to think about. The colonoscopy changes when you look at the bowel. If you looked with mucosal edema to increase vascularity and telangiectasias, probably from hypoproteinemia or portal hypertension. So it is a very common problem, and it's something you don't want to pursue. So right colon thickening, I always see. I never make much out of it. I describe it. An important tip. Now, I mentioned with cirrhosis and portal hypertension, you get varices. On arterial phase imaging, you want to be careful. Varices often are not shown. It's just simply too early. So in this case, for example, you might confuse varices with nodes. Is there a mass in the lower esophagus? Are there nodes present? What's going on? Well, when you go from the patient's arterial phase and then you go back to the venous phase, now you see the large varices. Lower esophagus, gastric fundus can be large, bulky varices which look identical to adenopathy, and you can confuse with adenopathy. You also can confuse it with an esophageal cancer, perhaps. Look at the extent of the esophageal varices and the varices along the celiac and SMA. So again, you need to be very careful. Here's a few more images. Again, MIP is really good for this, but again, it's important to be thinking about that possibility. Patients with cirrhosis get recanalization of the umbilical vein, as in this case, and you see varices going down and into the abdominal wall, nicely shown here, and then tracking down to the right inguinal zone. The portal vein was patent, but the patient has severe hypertension. The patient has severe congestive changes in the liver, and you have recanalization of a dilated umbilical vein with large collateral flow pathways, beautifully seen. So imagine doing a paracentesis for ascites or doing liver biopsy. You want to be very careful and stay away from the vessels. You also can see very nicely in this example, I'm showing you a number of different ways of looking at the patient's varices from volume rendering to MIP. Now, one of the things that is challenging in the liver, we talk about regenerating nodules, which go by a number of different names. But what's important is when you see them in a cirrhotic liver, and they're probably most common in patients like this with Budd-Chiari, you say to yourself, well, it could be a regenerating nodule, but how do I know the patient does not have multifocal hepatoma? It could be. I mean, you could say, how do I know it's not metastatic carcinoid, but you're dealing with an abnormal liver, so perhaps focus on regenerating nodules. Now, when you look at venous phase, the patchy enhancement of the liver consistent with underlying liver disease and Budd-Chiari is seen, and now you see the regenerating nodules again. They're present, they're not as bright. But what's interesting is when you look at the arterial phase and then you compare on the venous phase, the lesions are there, but they're larger on the venous phase. Now think for a second. If you have a hepatoma and you go from arterial to venous, Sometimes it becomes isodense. Sometimes you see it equally well, but sometimes you see it better arterial because the venous tends to be washing out. And in this case, it's less bright on the venous, but it's larger. Have you ever seen a lesion go from arterial to venous and then get bigger? No, it usually gets smaller with time. The only thing that does this is regenerating nodules. If I see a lesion getting bigger from arterial to venous in a cirrhotic liver, I'm thinking regenerating nodules. A couple articles about this. Careful attention should be paid to large nodules in patients with micronodular cirrhosis because of the risk of malignancy, and small hypoattenuating nodules should be more often followed up in shorter intervals than large nodules. So again, it's a difficult problem, this regenerating nodule. Sometimes MR is helpful. Again, usually it's just simply following the patients or having a high suspicion. And when you see multiple lesions that look the same, again, that change in size, I think it's a really good diagnosis of regenerating nodules. What else in the liver? Well, another term that we typically see is passive hepatic congestion. And typically it's due to cardiac disease, and it's usually poor right-sided heart function, which can be due to congestive failure, constrictive pericarditis, tricuspid atresia, tricuspid insufficiency, or just any reason for right-sided heart failure. Now, the fact is it may be irreversible even if cardiac function is improved. Now, what do you see? And this is very important because sometimes you're not scanning the chest, you'll only be scanning the abdomen, and then you need to say the patient has right-sided heart failure or decreased right-sided heart function. Please look into its cause. Well, what you typically see is retrograde flow of contrast into the IVC and hepatic veins. Now, recent articles have reported that to be seen in young, healthy patients. You may see it occasionally, but it's uncommon, and when you see reflux, you better be thinking about poor right-sided heart function. You may get mild enhancement of the liver due to congestion, hepatomegaly, ascites, and periportal edema. And here's just one nice example. Look at the reflux into the IVC. Look at the reflux into the patient's hepatic veins. Very nicely shown there and on the MIP imaging as well. When you see this kind of reflux, well, you can kind of see the heart at the top of the image. The heart is definitely enlarged. So you need to be very, very careful. Here's another example, looks very similar. Reflux of contrast into the IVC, into the hepatic veins, and you can see that reflux very nicely when you look at the 3D mapping. So remember, these are early phase images with that reflux coming backwards. Now, when you speak about liver disease, there are a number of different entities that come to mind. One is Budd-Chiari. It's an uncommon condition characterized by obstruction of the hepatic venous outflow tract. The presentation is variable from a symptomatic condition and incidental finding to fulminant liver failure. It is an example of post-sinusoidal portal hypertension. So what things do we see? Budd-Chiari is also known as hepatic veno-occlusive disease. The hepatic venous outflow obstruction may be global or segmental. Budd-Chiari may be chronic or acute in nature, and regenerating nodules are particularly common, and I showed you an example a few moments ago. The causes, the primary cause is membranous obstruction of the hepatic venous outflow tract, and the secondary causes are due to thrombosis of vessels due to causes ranging from chemotherapy or radiation therapy to hypocoagulability states or hepatic or extrahepatic tumors. But the one we typically think about is primary Budd-Chiari. Some of the causes: inherited hypocoagulability states from factor V through protein C and S deficiencies. You also can see it from acquired hypercoagulability states. Think polycythemia vera, think myelofibrosis as two examples, or PNH as the third example. It could also be due to acquired hypercoagulability states. Again, polycythemia vera, antiphospholipid syndrome are two things you need to think about. You can also see it in ulcerative colitis as well as in pregnancy, and it's one of the complications of oral contraceptives. Now, when you look at Budd-Chiari in terms of presentation, the majority of patients present with a subacute or chronic type presentation. Acute Budd-Chiari is only 20%, 5% with fulminant hepatic failure, and about 20% are asymptomatic and incidental findings. People have done some sorts of classification for Budd-Chiari, type 1, type 2, type 3, whether it's limited to the IVC or hepatic veins or involving both. When you look at the CT findings, the findings will vary depending on the phase of acquisition. In the arterial phase, you see a patchy enhancement with increased enhancement of the central portion of the liver. It's a very geographic type enhancement. You may see a large caudate lobe, you may see a very small or compressed IVC, absence of hepatic veins, ascites, and possibly the presence of regenerating nodules. In the acute phase, there may be early enhancement of the caudate lobe and central portions of the liver, as I mentioned, and you have this relative bright center, and the periphery shows decreased attenuation, which is a very unusual appearance. Not many things will do that, and when you see that, I'm always thinking Budd-Chiari. And then when you get delayed scans, there's delayed enhancement of the peripheral portions of the liver, and the central portion is of low attenuation, sort of a flip-flopping. What was high becomes low, what was low becomes high. And again, the hepatic veins and IVC may be small or poorly seen and hypodense. In the chronic phase, the IVC and hepatic veins may not be visualized, they may be occluded, and again, these hyperdense or regenerating nodules may be seen. With Budd-Chiari, depending on the situation, medical management with anticoagulant therapy can be done. Patients with long-standing Budd-Chiari or fulminant Budd-Chiari may need nothing short of a liver transplant. Endovascular therapy has become of greater interest. Angioplasty, stent placement, and catheter-directed thrombolysis are all things that are being done. And again, the goal is to avoid a liver transplant. A couple examples. Look at this Budd-Chiari, really patchy enhancement of the liver. It's not really kind of geographic. It's kind of a mottled appearance. Look how bright the caudate is compared to the rest of the liver. And then the periphery of the right lobe looks bright. You can see relative to the rest of the liver. And here you can follow it out a little bit. The IVC looks really flattened, and the hepatic veins are poorly visualized. Or in this example, you see the bright central portion of the liver on the arterial phase, and the periphery of the liver is relatively low attenuation. It's not really geographic per se for a segment of the liver, it's the entire liver. Center bright, periphery decreased attenuation, relatively speaking, and then when you go back later on, it inverts. I mentioned regenerating nodules before, and here's just an example of multiple regenerating nodules. Again, at times it's kind of tricky because it can be hard to separate from a very tiny hepatoma. Here's just a few more images. Again, when I see multiple nodules, I feel more comfortable with regenerating nodules, but we also mentioned that hepatoma can be multifocal, metastasis can be multifocal, cholangiocarcinoma can be multifocal, so it can be somewhat tricky reaching the diagnosis. As I mentioned, and at times, MRI will be very helpful in giving you further information. And here's just a few more images very nicely showing you the stretched vessels, showing you all of those nodules. Now, when you have Budd-Chiari and it's chronic, I mentioned you're not going to visualize the IVC or hepatic veins. You may see collateral vessels present, this mottled liver enhancement, the potential for seeing larger regenerating nodules, and a prominent caudate lobe. And here's just a good example of a patient who had a stent placed. You can see the regenerating nodule in the right lobe. You can see the mosaic pattern to the liver. That's a very good pattern for looking at Budd-Chiari. Now, another thing that we speak about that's becoming more common are liver abscesses. Now, we know usually liver abscesses are related to some sort of history, foreign travel perhaps, patients with recent surgery, patients with diverticulitis, appendicitis, you name it. But we are seeing infectious disease involving the liver more commonly. And it can be anywhere from pyogenic to fungal to amoebic. About 90% of abscesses are pyogenic, with E. coli being the most common. And again, clinical history is very important, though I will admit the clinical history of liver abscesses and primary metastatic liver lesions can be very, very similar. When you look at liver abscesses, often they're cystic, but you don't confuse them with cysts because in a case like this, if this was a simple cyst, how do you explain all of the perfusion changes around the liver? So these liver abscesses, particularly from E. coli, can be cystic in nature, they can be solitary, they can be multiple, and it's very common to see those kind of perfusion changes. Pyogenic abscesses most commonly involve the right lobe of the liver, so does Hydatid disease. Air fluid levels make the diagnosis fairly straightforward, but air fluid levels in liver abscesses and splenic abscesses happen far less than 25% of cases. We talk about another sign where there are multiple small clusters of lesions present, the so-called cluster sign, and that also represents abscesses. And as mentioned, abscesses can be single or multiple. There's a range of abscesses. Sometimes they overlap in appearance, sometimes they can be suggestive. Obviously, something like Hydatid disease, rim-like calcification, or daughter cysts. We talk about fungal abscesses. Patients are usually immunosuppressed, and there are many small lesions present on the sonometer, and often coexistent disease in the spleen as well as in the kidney. We talk about amoebic abscesses, again, foreign travel, most commonly South America, and air fluid levels, and occurring in the right lobe of the liver. Now, it's interesting, this patient came to Hopkins with weight loss and fever, but the history really pointed to malignancy. This patient had a biopsy to see what the primary was. The primary was a large abscess due to E. coli. The patient's history was fever and weight loss and the dwindles. It sounded like a malignancy. It was a street person. But you got to think about hepatic abscess, and this indeed was a hepatic abscess. As I mentioned, some of the key facts with pyogenic abscesses caused by hematogenous spread from the GI tract, ranging from ascending cholangitis to infection of the necrotic tissue. E. coli is number one. Clinical presentation, fever, right-sided abdominal pain, even weight loss, and elevated liver function tests. And you can see why this would overlap a lot with tumor, particularly in a patient with known tumor. So it can be somewhat tricky. When you talk about pyogenic abscesses, they can be single or multiple. They can range from a few millimeters to several centimeters. They may have rim enhancement. They may have septations, rarely have calcifications, and air within the abscess is indeed something that makes the diagnosis fairly straightforward, but I will say that the abscesses containing air are far less than 20% of abscesses. Now, sometimes it's kind of tricky. You look at this lesion in the liver. This is a 20-ish-year-old, had fever. We saw this. We were doing a workup to rule out anything. Couldn't explain the fever. And I saw this lesion. It's kind of low density and well-defined, but I agreed when I looked at it and looked at the vascularity, it wasn't a simple cyst, but it didn't look like a metastasis. It's well-defined, but it's about 40 Hounsfield units. I thought about an abscess just because the patient had so many different symptoms. This was biopsy. It was the only thing we found in the patient, and it ended up being Hydatid disease. The patient had been to Mexico for a week at spring break, and somehow or other ended up with Hydatid disease, even though the patient was native from Baltimore. So even when you're not thinking about fungal disease or Hydatid disease, or something we typically say it's foreigners, well, if you travel to foreign countries, you may be the person with that disease. Now, with hepatic abscesses, we also think about Hydatid disease, classic parasite-type infection. Usually these patients have eosinophilia, but it's hard to make the diagnosis. Classic for amoebic abscesses, foreign travel, South America, and it's a multi-cystic lesion. You see this lesion, it has sharp walls, you can see them with the contrast, but it has like multiple cysts within it. When you have nodules and cysts, then I think about Hydatid disease, but amoebic abscesses, very common with an air fluid level, very common posterior right lobe. You can see as you go from arterial to venous and delayed, the cystic components, sort of a cluster sign, shows much better, and this was an amoebic abscess. Amoebic abscesses are interesting. It's the most common extraintestinal manifestation of amoebiasis. Again, common locations, India, Far East, Africa, and South America. Patients are usually very sick, and again, the travel history is critical. The lesions are cystic within the liver, as I showed you. You may have an enhancing rim, you may not. There's often edema around the lesion, which is common with abscesses, but also can be common in vascular metastasis. Amoebic abscess can be a cluster, but more commonly are single lesions. Now, what about this case? Well, this case is kind of easy. This patient was a febrile patient who had a bone marrow transplant. Right away, you're thinking differently. You see multiple low-density lesions in the liver. Now, perhaps this is tumor, but the patient did have a normal liver a few weeks ago and now is febrile. I also see a lesion in the spleen. And I look more carefully, there are multiple liver lesions present. I look carefully at the kidneys. There are no renal lesions present. and that is infection. And again, what type of infection? Immunosuppressed patients, you got to be thinking fungal. Candidiasis is the one you think about. High percent of the time, liver and splenic involvement. High percent of the time, liver, kidney, or liver, kidney, and spleen. So again, something very important to think about. Now, in terms of lesions, one of the lesions that really can be confusing is this lesion, hepatic infarcts. They can be solitary or they can be multiple. Like every infarct, they're peripheral, they're wedge-shaped, and if you think about it, you can make the diagnosis. Now, it's interesting, hepatic infarcts most commonly are patients who are post-op, but you also can see them in patients who have endocarditis, patients with septic emboli. What can be tricky, and I mentioned fatty infiltration of the liver before, wedge-shaped peripheral focal fatty liver can simulate infarcts. I think the big difference here is they're also wedge-shaped. It really has to be infarcts. There are a range of causes from infarcts, from occlusion of venous structures to emboli, to a patient like this who's post-liver transplant with fever, very large infarct of the patient's portal vein. You can see the larger infarct as well as multiple small infarcts. That's the appearance. It almost looks like necrotic liver, which in fact it indeed is. You can see when you're looking at a patient post-liver transplant, you look carefully at the hepatic artery. In this case, you can see the hepatic artery is occluded proximally, and when you have that occlusion, it's no surprise that the patient will develop hepatic infarcts. And you can see as I go through the images, the cutoff of the patient's hepatic artery very nicely shown, and then subsequent infarcts. Now, occasionally with infarcts, as is true with spleen, as is true with kidney, you can go from infarct to abscess. This is a patient post-liver transplant with the hepatic artery occluded, and now look at the liver. The liver looks necrotic. Now, it's easy to see an abscess when you see air in the liver, but only about 15% or so of abscesses will have air. So if you only wait to see air, and the same thing is true in the spleen, and the same thing is true in the kidney, you're going to miss lots of abscesses. But when you see air, it's typically going to be an infarct. Now, I mentioned about abscesses that they're one of the challenging lesions that can simulate malignant tumors. There are a number of other things that can simulate malignant tumors, and one of them indeed is sarcoid. I like sarcoid because it is one of the great mimickers. We think about sarcoid as mediastinal nodes, eggshell calcifications, parenchymal lung disease and scarring and retraction, but almost any organ can be involved. And the numbers like liver involvement are indeed very high, 94% in one series talking about this. Most patients are asymptomatic, and the most common finding is hepatomegaly. Now, it's rare to see specific lesions. If you see specific lesions, you might be thinking about a malignancy. The same thing is true in the spleen. Now, in this case, you can see both splenic and hepatic lesions, and the first thing you're thinking about, of course, is malignancy. You may be thinking about lymphoma, you might be thinking about metastatic melanoma. Well, sarcoidosis can involve both organs. The hint is if you had malignancy, you'd be very sick, weight loss, fever. Here, patients have vague symptoms at a CT for another reason, and voila, you see what looks like incredible disease, and you got to be thinking sarcoidosis. Invariably, in most of the cases I've seen, there's no history of sarcoid. Nobody was thinking of sarcoid. The same thing in this case. And I've seen that in healthy young women, people in their 20s and 30s. So it's something indeed to think about. Often you'll go back and you'll scan the patient's chest and you'll see adenopathy. But again, when you look at it, you can say, how do I know it's not lymphoma? How do I know it's surely sarcoid? Lymphoma can give you adenopathy. Lymphoma gives splenic and liver involvement. How do I know? Well, it's something to think about, and then of course you can do a biopsy and prove it's sarcoid. But invariably, if you had lymphoma or another malignancy, you would be very sick. These patients had a CT scan for a very minor reason, and usually it was an incidental finding, maybe trauma or some vague symptoms, but nothing that would explain the extent of disease that we could see here. So it's a very important, great mimicker. And I've seen patients worked up for primary malignancies. What's the source? What's the primary? Because it's assumed this is metastatic. So you got to be thinking about sarcoid. Another thing that can be a great mimicker or can be problematic in terms of diagnosis, hepatic vascular pathology, from portal vein thrombosis to hepatic artery aneurysms to AP shunting to AV malformations. Now, portal vein thrombosis, we see in many conditions. It can be partial or it can be totally occlusive. It can be associated with acute processes or chronic processes ranging from pancreatitis to hepatoma. There's really a long list of benign and malignant conditions. We see portal vein thrombosis or invasion all the time in pancreatic cancer. We also see it in hypercoagulability states involvement, and we also see it in patients with cirrhosis. When you have portal vein thrombosis, on the arterial phase imaging, perfusion is usually increased, and on venous phase imaging, you're better able to see the thrombus, you're better able to see perfusion changes, as well as collateral vessels. And here's just a nice example with partial portal vein thrombosis and some of the perfusion changes in the liver. Again, you want to be very careful. Portal vein thrombosis can extend into splenic vein and SMV. You want to look at that carefully. And the enhancement patterns can be very variable. The changes in this case really are indeed very minimal, and it's really not all that impressive. In other cases, it's substantially more impressive. If you look at this case with portal vein thrombosis, you also see cavernous transformation of the portal vein. There are multiple collaterals present, and when you start looking at the perfusion changes within the liver, you see the clotting coronals. Coronals are very good for looking at the portal vein or SMV or their confluence, and you see multiple collaterals in the hilum of the liver, very nicely seen in this example. And you can see as I run through a series of some of the images, the collaterals around the hilum of the liver. One interesting thing that we rarely see are portal vein aneurysms. We've seen a couple of them. They're associated with cirrhosis, usually off the main portal vein, and they can be large. And here's just one example of a large portal vein aneurysm. The thing is, you can simulate tumors, particularly on later phase imaging, or on non-contrast scans. So it's something to at least recognize and be aware of. We did publish an article several years ago about that that's still in press. And portal vein aneurysms are the most common of the visceral venous aneurysms. They're quite rare, but they do occur. So it's something indeed to be thinking about, though again, it's a very uncommon, very unusual type process. Now, when we talk about splanchnic artery aneurysms, one of them that we talk about is hepatic artery aneurysms, and hepatic artery aneurysms are the second most common splanchnic artery aneurysm after the splenic artery. You can see very nicely they can be single, they can be multiple. Look at this example. Look at the multiple hepatic artery aneurysms. Now, if I see multiple hepatic artery aneurysms, I like to think about some complication of a disease process. This was a patient with Ehlers-Danlos. You can see not only the portal vein aneurysms, but aneurysms off the SMV. So when you start seeing lots of aneurysms, you got to be thinking about some sort of vasculitis. And here's just a couple very nice images to give you a range of perspectives with volume rendering and with MIP. Now, there's a disease called HHT, or hereditary hemorrhagic telangiectasias, and in that disease, we typically scan patients looking at the lungs for PAVMs, and those are often embolized. But they also get hepatic AVMs, which are only seen typically in arterial phase imaging. Indeed, very, very impressive. When you go to venous phase, these lesions are basically gone. We talk about this disease also being known as Rendu-Ausler-Weber disease. Telangiectasias and AVMs are most commonly in the skin, lung, GI tract, and brain, particularly the liver. Okay. Again, we typically are looking at the lung because that's really where the most common symptoms are, recurrent spontaneous epistaxis, for example, but we will see the areas of involvement going beyond the lung. Now, just a couple numbers, 20 to 50% have PAVMs, and in 60% of cases, it's multiple, but usually asymptomatic. But these will often need to be embolized. Number two would be liver, up to 30% of cases, but more than half of patients are asymptomatic. When patients are symptomatic, you might see high output heart failure, portal hypertension, or biliary cystic disease. And again, the CTs are indeed very impressive. I mention HHT in part because we have a clinic at Hopkins, and we see a lot of these cases, and the first time you see them, it's indeed very, very impressive. There's been a few articles talking about HHT and some of the variations, and I'll show you a couple examples. Here's a patient with multiple PAVMs, including some that have been embolized, And here's the patient's liver. Very impressive AV shunting, very impressive hepatic AV malformations. Okay, just another set of images. And here's a different patient with multiple smaller AV malformations. Again, as I mentioned, if you go to venous phase imaging, you're never going to see these lesions. So arterial phase imaging is indeed critical. Can you mistake this for something else? Well, does it look like multiple small vascular mets? But when you follow the vessels and they're intertwining, you look at the lungs, it's not going to be a difficult diagnosis. And as I mentioned, same case, venous phase imaging, everything is gone. So again, it's really arterial phase diagnosis, and here the images are side by side. Since I mentioned AVMs, let me just mention that AV shunts are not uncommon in the liver, often from prior trauma or prior biopsy. You can see them when you're very careful looking at the images. What you want to make certain is you don't confuse a AV shunt with a vascular tumor like a hepatoma or a metastatic lesion. We also talk about other perfusion changes, the so-called hot spot in the liver in a patient near the falciform. In a patient with SVC occlusion, you get collateral flow, and it can simulate a lesion. Very nicely shown on the 3D imaging. You see the collaterals into the abdominal wall, intercostals, internal mammary, but a beautiful visualization of that hot spot. And again, the key is it's only seen in arterial phase imaging. It becomes isodense, and the key thing is not to confuse it with a metastatic lesion. Very, very nicely seen and really nicely shown on these MIP imaging. So again, it's sort of a pearl and a pitfall combined together. The other thing that's good about this, if you see that hot spot and you only scan the abdomen, you have to suggest the patient has SVC occlusion from whatever cause, be it benign or malignant. But that's how it looks. Another example, SVC occlusion. Not only do you see the hot spot in the liver, which is very large, but you also see collaterals in the chest and abdominal wall. Indeed, very, very impressive. You see this patient has end-stage renal disease. The patient had multiple catheters placed over time. The catheter and the SVC for access eventually occluded. Patient has SVC occlusion. So SVC occlusion can be due to many things. It's not always going to be malignancy. It can be seen in patients who've had chronic IV access through the SVC, and just a very impressive picture. In terms of enhancement, I'll just mention these AV shunts are important to not confuse with malignancy. Again, they become isodense. You can see the feeding and draining vessels, very nicely shown in this example. So I do mention them. Again, usually trauma is a cause, but they can be just hereditary. The big thing about them is not to confuse them with malignancy. So I've gone through a number of different conditions. Here's just some of them I've spoken about. I've tried to highlight some of the pearls and some of the pitfalls, shown you a number of examples, discussed the potential importance of each of the diagnoses. We talked a little bit about protocol. And with that, we'll stop, and I'll thank you for your attention.